Hi, this is Dr. Ross, and this is the slideshow presentation for From Fertilization to Birth, and it is part of the Unit 6 reproductive system. So let's start with a review of fertilization, which of course involves the fusion of two haploid gametes. Remember, these are cells containing 23 chromosomes, half the total number of chromosomes in a typical cell, or a typical human cell. These gametes, of course, are the spermatozoa and the oocyte. So the spermatozoa are deposited in the vagina, usually just below the cervix or external os. And then next, the sperm must travel a relatively long distance. It must swim through the cervical canal, through the lumen of the uterus, and the uterine tube. Interestingly, it's not completely understood how the sperm finds the egg. Based on the sperm motility, it should take several hours to make this long journey, but it typically can be accomplished in under 2 hours and in sometimes as little as 30 minutes. One hypothesis is that contractions of the uterine muscles and the ciliary currents, so the currents created by beating of cilia, decrease this transit time. So let's back up a little bit. The secondary oocyte is ovulated from the ovary and captured by the ciliary action of the fimbriae. Then it is wafted down the uterine tube to the ampulla, where it may be fertilized. So before I move on to the next section, I just want to say that while it's true that only one sperm is going to fertilize an oocyte, dozens of sperm are actually required for successful fertilization, so just keep this in mind as I go through the next section. So when the sperm arrives at the egg, acrosomal enzymes from dozens of sperm digest or degrade a tunnel through the zona pellucida. Ultimately, a single sperm fertilizes the oocyte. So fertilization begins when an oocyte completes meiosis and forms the ovum. Fusion of egg and sperm pronuclei will create a new whole nucleus. So this is going to be a nucleus containing 46 chromosomes. It'll be genetically complete. This results in a cell called a zygote, and this will ultimately give rise to a new person. So now let's discuss the hormones of pregnancy. So at implantation, the chorion of the blastocyst secretes HCG to rescue the corpus luteum, keeping enough progesterone around to maintain the uterine lining. Just as a side note, HCG is actually what's detected by the pregnancy test that you purchase at the store. So an important switch in hormone production occurs during the next stage, the embryonic period. So during the embryonic period, the placenta begins to secrete estrogen and progesterone, taking over the endocrine control from the ovary. Now, progesterone acts to maintain the pregnancy by supporting the lining of the uterus, so it prevents shedding of this lining, and it suppresses the ability of the muscle layer of the uterine wall to contract. So that's going to help prevent labor from occurring before the end of pregnancy. The estrogen levels will rise towards the end of pregnancy, and this will stimulate the growth of the uterus to accommodate the growing fetus, and eventually it will allow the uterus to contract by countering the effect of the progesterone. It also stimulates the growth and development of mammary glands. So during the fetal period, new placental hormones appear, relaxin, CRH, and HPL. So relaxin is known to act in other mammals to relax ligaments to allow for easier parturition, but this has not been proven in humans. But if, it's thought that it occurs, and it may explain the decreased stability and difficulty in maintaining balance that some women may notice later in pregnancy. CRH is there to add fuel in the form of glucose and ketone bodies to women's blood. And this occurs as the baby starts to increase in weight significantly. But what this can mean for the woman is physiologically she is in a state of stress for the whole third trimester or so. This is said to account for that healthy glow of late pregnancy, but is also accounts for the water retention and the production of aldosterone. The function of the HPL, or human placental lactogen, is not completely understood. HPL analogs are known to promote mammary development in other mammals, but this has not been proven to do that in humans yet. So let's get down to labor. So two types of labor, false labor and true labor, occur. False labor, which is also known as Braxton-Hicks contractions, they are defined by the fact that they are irregular, they're relatively weak, and they will stop if there's a change in movement or position. These do not lead to cervical changes or to the 3 stages of labor. They're basically just considered spasm of the uterine muscle. Now, true labor contractions, these are contractions that are strong and occur at regular intervals. They will increase in intensity and regularity, and they do not go away with movement, unlike Braxton Hicks. They do result in changes to the cervix. The fetal and maternal hypothalamus release oxytocin when this occurs, and this causes the placenta to release prostaglandins. Interesting, the fetal hypothalamus is thought to initiate the oxytocin positive feedback loop when the baby thinks it's ready to be born, although this has been difficult to prove. The cervix will soften and begin to dilate. In addition, cervical stretching and dilation will initiate that positive feedback loop. So once labor contractions have begun, and the positive feedback will ensure that they will continue until delivery has been completed. So the stages of labor, which has traditionally been divided into 3 stages: dilation stage, expulsion stage, and the placental stage. So the dilation stage begins with the onset of true contractions and ends when the cervix is dilated to about 10 centimeters and mostly effaced, which means the fetus begins to shift toward the cervical canal. And that's aided by movement, that's aided by uterine contractions and gravity, good old gravity. It is the longest and most variable stage, and it can last anywhere from 4 to 24 hours. The expulsion stage begins at complete dilation of the cervix. The landmarks include crowning of the baby's head, full expulsion of the baby's body. It's typically faster than dilation, but it can still last anywhere from 30 minutes to several hours. The placental stage is the last stage, and this is the delivery of the placenta and fetal membranes, and so it must be accounted for. It typically takes less than 30 minutes. Now, immediately following birth, we have the postnatal period, which is the first 10 minutes. So here we have our delivered baby, which is called a neonate. During this time, the first breaths will inflate the lungs. The first breath will also initiate circulatory changes. It will close the foramen ovale immediately. The ductus arteriosus will also close, but this is going to happen over the course of a few months. Now, if one of these does not close, this will result in a heart murmur. Loss of the placental circulation also causes the placental vessels to collapse and become ligaments. During this time, the APGAR score is taken, and that's going to happen at 1 minute and 5 minutes after birth, and it's there to measure the baby's adjustment to life outside the womb. It's named after Dr. Virginia APGAR, it's also an acronym or backronym. So here we have APGAR, and this defines what the test is looking for. So you have appearance, so the skin color. Basically, you don't want the skin to be blue, which would signal a lack of oxygen reaching, getting through the circulatory system. You look at the pulse. They want to know what the heart rate is. They want to see that it is higher than 100 beats per minute. Grimace, what this refers to is the reflex response to irritation. They want a grimace and cough or cry. This is what they're looking for. Activity. Activity demonstrates muscle tone, so they want some sort of active motion. Finally, respiration. They are looking for regular respiration and a really strong cry at this point. So each of these factor scores a 0, a 1, or a 2. And they're hoping for a score that's 7 or higher, and you can get anywhere from 0 to 10. And if it's low, this could suggest some things about the neonate. So on the postnatal period, this is going to be during the first 6 weeks. What happens during this time is a rapid drop in estrogen, progesterone, and CRH level, which can cause what's referred to as the baby blues. More serious versions are called postpartum depression or PPD or postpartum psychosis, PPP, and this, of course, can require psychiatric treatment immediately. Prolactin and oxytocin drop. They'll drop some, but they're going to spike when the baby nurses, and this is going to promote bonding as well as milk production. For a few days, the mom will produce colostrum, which is very rich in antibodies, and it's also a laxative. As the nursing cycle kicks in, the true milk is produced, and that's going to contain growth factors, fatty acids for brain growth, enzymes, and antibodies. There's going to be 2 to 6 weeks of uterine bleeding called lochia. There will also be an increase in urine and sweat to clear out retained water. Now, before I move on, I want to take a second here to discuss breastfeeding and pregnancy prevention. So when breastfeeding exclusively, and I mean exclusively, every 4 hours or more, your body will naturally stop ovulating. And so if you're not ovulating, you really can't get pregnant. However, this is not a super reliable means for birth control. Because one, breastfeeding must be exclusive and frequent. So every 4 hours during the day, if not more, and at least every 6 hours at night. And it has to really be prior to 6 months of age for the baby. Once that occurs, the reliability of this completely reduces or drastically reduces. Now, also keep in mind that you can ovulate before your postpartum period return. So there's going to be no visual indication that you're fertile. So again, this is not 100% effective. And if you're really trying to prevent pregnancy after birth, it's best to rely on other methods. The next step we're going to talk about in the reproductive life cycle is puberty. So surprisingly, the exact cause of puberty onset is still unknown, but at some point, the biological clock is going to tell the hypothalamus to start secreting GnRH, and that's going to tell the anterior pituitary to secrete FSH and or LH. And this will ultimately instruct the gonads to mature and start secreting sex hormones. So after the sex hormones are secreted, there will be some noticeable events. For the boys, there's going to be enlargement of the penis and testes, pubic and axillary hair will develop, and body odor and acne will develop. In girls, there's going to be development of breast buds, pubic and axillary hair, and body odor and acne as well. Other landmark events will occur. This is going to include the boy's first ejaculation, which is called spermarchy. At around age 13, the voice will change, and at around age 15, facial hair will develop. And this is going to occur gradually as puberty progresses. For girls, they're going to have the first menstruation, called menarche, at around age about 12 and a half. And the first ovulation will occur about a year later, although it can vary. So you can really, young girls can get pregnant during this time. You can even get pregnant before you have your first period if you begin ovulating before then. So there's some weird guideline about not getting pregnant during that time. It's completely inaccurate and should not be trusted. All right, so moving on to older adult issues. Reproductive systems function throughout most of adulthood until women and men reach their later years. So women in the late 40s to early 50s will stop producing mature gametes. They will enter perimenopause, and this is characterized by a drop in estrogen and irregular or very light periods. Menopause is defined as 1 year of no menstruation. Obviously, this doesn't account for pregnancy or birth control. A reduction in estrogen and progesterone has many effects, among them reduction in size of breast, atrophy of the uterus, thinning of the vaginal lining and mucus. Some women experience hot flashes, thinning of scalp hair, and growth of facial hair. There's also a decrease in bone density called osteopenia, and you have a risk of osteoporosis due to that. And this is due to the fact that with little estrogen there's not really a good stimulation of osteoblasts. Increased risk of heart disease is also a real concern. Hormone replacement therapy alleviates these negative effects, but it can also increase a risk of certain cancers. Now, men in their 50s begin to experience a climacteric. Testes shrink slightly, testosterone levels decline, called an andropause. The sex drive declines, as does sperm production, and that can lead to erectile dysfunction or impotence. It can also lead to depressed mood, hot flashes, feelings of lost energy, and a loss of muscle tone as well. The prostate often begins to enlarge, and this can affect urination. The testosterone replacement therapy has become popular, but it can exaggerate that prostate problem, which can lead to other problems as well. So, the very last slide of Anatomy and Physiology 2, congratulations, you've reached it. Hopefully, this is not the end of your education in the human body and healthcare, but just the beginning. So, good luck, guys.